This is an educational video for patients and their families or anyone interested in Tuberous Sclerosis Complex or TSC. TSC is a rare multisystem genetic disease characterized by the development of benign tumorous growths called hamartomas. The disease is highly variable in its presentation, which makes diagnosis criteria difficult to define. The disease commonly causes tumors in the brain, kidney, heart, lungs, eyes, and skin, and common symptoms will include intellectual disability, seizures, skin lesions, and more. In this video, we will discuss epidemiology, pathophysiology, and diagnosis, the major and minor features of TSC, and lastly, the differential diagnoses, disease surveillance, and approaches for disease management. You can use the links provided in the description of this video to easily jump to any of the sections. The current prevalence of TSC is estimated to be 1 in 6,000 newborns, with no preference for race or gender. The population prevalence is 1 in 10,000. Issues in the accuracy of this information result from less frequent reporting in more mild cases, the variability of symptoms, and reluctance to undergo diagnostic testing. Tuberous sclerosis currently affects 25 to 40,000 individuals in the United States and about 1 to 2 million individuals worldwide. Seizures are experienced in 90% of cases with TSC and cause intellectual disability and cognitive impairment later in life. Early detection and management of seizures is very important. In 1984, a study found 68% of patients with tuberous sclerosis have developmental delays, and more recent studies put the statistic between one-half to two-thirds of patients. All individuals with developmental delays had seizures, and 42% of individuals without developmental delays had seizures as well. While individuals can be diagnosed at any time throughout their lives, many are diagnosed at a very young age. Younger individuals diagnosed with TSC are more likely to have developmental delays. However, this is certainly due to a selection bias, as those without delays are yet to know about their disease, as they have not yet developed symptoms associated with the disease that would prompt them to seek a diagnosis. Prognosis is highly variable and depends on the severity of symptoms. Individuals with mild symptoms can expect a normal life expectancy if properly monitored. More complex disease leads to more severe developmental issues and epilepsy, and also puts you at greater risk for life-threatening diseases such as brain tumors, kidney lesions, or LAM. Morbidity primarily arises from neurological diseases, including epilepsy and SEGA, or subependymal giant cell astrocytomas, with associated hydrocephalus. The second most frequent morbidity comes from renal disease, in which enlarging AMLs can cause hemorrhage, and end-stage renal disease from destruction of renal parenchyma, and polycystic kidney disease. Pulmonary or cardiac disease is less common. Tuberous sclerosis is an autosomal dominant disease with a high rate of spontaneous mutation. Because the mutation is autosomal dominant, it will be passed on to 50% of the offspring produced by an affected parent. However, only about a third of all individuals with TSC inherit the disease from the parent. A high rate of spontaneous mutation means that two-thirds of individuals with TSC did not have parents also affected with the mutation. There are two distinct mutations located on two different chromosomes that cause TSC. The first gene is called 9q34, also referred to as TSC1, and the second is on chromosome band 16p13, or TSC2. The numbers 9 and 16 respectively refer to the chromosome that the gene is located on. The TSC1 gene is responsible for generation of the protein hamartin, which acts as a tumor suppressor. The protein of the gene TSC2 is the protein tuberin, whose GTPase activating abilities lead to tumor suppression as well. Both hamartin and tuberin are thought to interact via their coiled coil domains, and this suppressor complex is thought to drive the signaling molecule Rheb into its inactive GDP-bound state, which will in turn downregulate mTOR. The mTOR pathway has been studied extensively within the cancer setting, and thus there is already development of drugs and clinical studies looking at the regulation of this pathway. mTOR is an important molecule because it's responsible for regulating cell growth and protein synthesis. Mutations to the TSC1 and/or TSC2 genes can either completely stop production of protein or can alter protein production in the case of missense mutations. The result is the highly variable presentation typical of tuberous sclerosis. This has led to a second hit theory, which states that in addition to the inherited or sporadic mutation of either TSC1 or TSC2, the other unaffected gene may also undergo some type of mutation in order to see clinical manifestation of symptoms. The interaction of these two proteins, of various functionality and from two mutated genetic locations, leads to the variability observed in patients with TSC. Another interesting note is that through a process known as genetic mosaicism, the parents of an affected individual are at greater risk of having another child with the disease. This occurs because a portion of the gonadal tissues within the patient may have undergone mutation early on in the differentiation cycle, meaning that the remaining sex cells are still impaired with the same mutation. When looking at the distribution of mutations associated with TSC, genetic testing has revealed that 80 to 90% of affected individuals have a mutation of TSC2, while only 10 to 20% have a mutation of TSC1. Certain individuals were also found to show no visible mutation, and likely they are mosaic for TSC2 mutation. This is a different type of mosaicism, where early in fetal development, one portion of the cells will develop a mutation, while the others will not. The TSC2 mutation has been correlated with more severe symptoms, including more frequent seizures, mental impairment, kidney involvement, and cortical tubers, and patients with no visible mutation also showed these more severe disease manifestations. Early diagnosis of TSC is very important so that surveillance can occur to detect manifestations before they become more serious. The most recent diagnostic criteria come from the 2012 International TSC Consensus Conference, which updated the diagnostic criteria from a 1998 conference. The most notable change to the diagnostic criteria is the inclusion of genetic testing. Individuals who identify as definite cases, according to the older clinical criteria, will test positive on the new genetic tests 75 to 90% of the time. The panel decided to make genetic testing an independent diagnostic criteria, meaning that a positive genetic result will be sufficient for diagnosis of TSC, regardless of clinical symptoms. This facilitates earlier treatment in younger individuals. The clinical diagnostic criteria require two major features, or a major feature with at least two minor features for a definite diagnosis, or either one major feature or at least two minor features for a possible diagnosis. We will now look at the major and minor features of TSC as defined by the International TSC Consensus Conference. We will now examine the major features seen in tuberous sclerosis. There are 11 of such features, and we will go through all of them individually. The first major clinical feature are hypomelanotic macules, which require at least 3 patches of skin without pigmentation that must be at least 5 millimeters in diameter. These spots typically become identified in early infancy in 90% of patients with TSC, and they have formerly been known as ash leaf spots. Facial angiofibromas occur bilaterally over the nose and cheeks of 75% of individuals with TSC, and are more common in childhood and late adolescence. These reddish, flat, macular lesions develop more commonly in individuals with TSC, and thus the presence of at least 3 angiofibromas can be considered a major feature of TSC. Fibrous cephalic plaques, while less common than facial angiofibromas, are the most specific skin finding for TSC. Skin biopsies have determined these dermatological conditions to be histologically similar, and thus they are grouped together as one diagnostic criteria. The presence of at least 2 fibrous growths around or under the nails of the fingers and toes is a major feature of TSC. This is one of the less common dermatologic findings, with an incidence of around 20%, but this can grow to 80% in older patients with TSC, as the onset is typically later on in life. Shagreen patches commonly appear on the lower back area of 50% of individuals with TSC. These large plaques of excessive fibrous material often appear to have a pebbly or orange peel-like texture. The presence of more than one retinal hamartoma is common in 30 to 50% of TSC patients. These growths have the same composition as tubers, which grow in the CNS of people with TSC. These lesions are usually not detrimental to an individual's eyesight, but they do occur very early in the disease and may be used in identifying a case when other dermatological features are yet to present themselves. Cortical dysplasias are congenital abnormalities caused by the improper migration of neurons during the development of the brain. The presence of two sites of abnormal neural formation suggests a major feature of tuberous sclerosis. The most common type of these dysplasias are cortical tubers. Cortical tubers are the feature most commonly associated with TSC, occurring in 90% of cases. Cortical tubers are pockets of disorganized neurons that arise mainly in the cerebral cortex and lead to defective formation of neurons. Depending on the location of the tuber, they can lead to seizures, difficulties in cognition, and motor, sensory, or reflex issues. Epilepsy is a major consequence of TSC, with recent estimates at 60% of cases suffering from seizures. Subependymal nodules are benign growths along the ependymal lining of the lateral or third ventricles. These major features occur in up to 80% of individuals with TSC and are often discovered prenatally or shortly after birth. Subependymal giant cell astrocytomas, or SEGAs, are a continued growth of the subependymal nodules previously mentioned, and are thus histologically very similar. SEGAs are less common, occurring in only 5 to 10% of cases, and develop during puberty and into adulthood, where they become problematic. SEGAs can block the ventricles, causing hydrocephalus, and subsequently blindness, nausea, headaches, and other neurological deficits. As a result of these tumorous growths in the brain, neurological dysfunction is a common feature of TSC. This includes aggressive behaviors, autism spectrum disorders, intellectual disabilities, psychiatric disorders, neuropsychological deficits, as well as school and occupational difficulties. Many children with TSC will have attention-related disorders such as ADHD, while other children and adults will typically suffer from mood disorders like anxiety. Cardiac rhabdomyomas are benign lesions that can grow in any of the four chambers of the heart but are typically found in the ventricles. While these growths are often asymptomatic, they occur early in life for 50% of TSC cases and are often found prenatally or in the first year of life. Rhabdomyomas cause disruption of outflow and valvular function, but the symptoms will typically recede as the patient ages and grows. Lymphangioliomyomatosis, or LAM, is a manifestation that preferentially affects female cases with TSC. The disease can also occur spontaneously due to a mutation of the TSC2 gene and does not necessitate the person have TSC. LAM is histologically characterized by the infiltration of smooth muscle-like cells into all areas of the lung. This eventually leads to a loss of elasticity in the lungs and will lead to hypoxia, the lack of oxygen, and pulmonary hypertension. Other types of pulmonary disease associated with TSC include pulmonary cysts and multifocal micronodular pneumocyte hyperplasia, which is the development of nodular densities. These features are common in TSC cases, but are not as dangerous as LAM. There are 4 renal manifestations linked with TSC. The only major feature considered in a clinical diagnosis is the finding of at least 2 angiomyolipomas, or AMLs, associated with the kidneys. AMLs are benign tumors composed of fat, smooth muscle, and vascular tissues. They are found in 80% of individuals with TSC and are typically discovered after the age of 3. These tumors can present as flank pain and a variety of renal dysfunctions. The deformed vasculature in these lesions often leads to aneurysms, which can have potentially life-threatening consequences if the vessels rupture. These tumors continue to grow as the individual ages, and the larger the tumor, the larger threat for hemorrhaging. The other types of renal manifestations associated with TSC include cysts, polycystic kidney disease or PKD, and renal cell carcinoma or RCC. Renal cysts alone are not dangerous, but their presence along with AMLs should suggest a diagnosis of TSC. PKD is a genetic disease associated with the mutation of 2 genes, one of which is the TSC2 gene. Thus, patients with TSC are at greater risk for PKD, which causes formation of abnormal renal tissue, frequent UTIs, and possible transplantation required. RCC is more common and occurs earlier in life for individuals with TSC, and is characterized by a rapidly expanding mass without evidence of hemorrhage or adipose tissue content. In addition to the major features, there are 6 minor features which provide supporting evidence for a diagnosis of TSC. We will now examine each of these features. Confetti lesions are identical to hypomelanotic macules, however are smaller and more common in the general population, and are thus considered a minor feature. These are diagnostic in children, but not adults, where confetti lesions are very common and can be symptoms of sun damage to the skin. The presence of at least 3 dental enamel pits are a minor feature of tuberous sclerosis. These are randomly distributed among the teeth and have the appearance of small pits or divots. Intraoral fibromas are small, fibrous lesions found primarily in the gums of the mouth, but can also appear on the tongue or other intraoral sites. They are a minor feature when at least 2 of these are detected. Retinal achromic patches are hypopigmented areas appearing on the retina. They are reportedly more common in cases of tuberous sclerosis than compared to the general population, however are generally non-symptomatic. As previously mentioned, renal cysts are not typically harmful, however appear more commonly in cases of tuberous sclerosis. Thus they are considered a minor diagnostic feature. The final minor feature are benign lesions which will occur outside of the kidneys. These growths will typically occur in the liver, pituitary gland, pancreas, and gonads, but are typically non-threatening. Because of the multifocal nature of the manifestations of tuberous sclerosis, features of the disease can often be attributed to other diseases or be considered as isolated findings. Many of the skin features may occur randomly in the population as isolated events, such as confetti lesions, which are common in older adults with significant sun exposure. In terms of CNS manifestations, the neurological features of TSC are easily distinguishable under proper imaging. However, many of the consequences of tuberous sclerosis, such as epilepsy or infantile seizures, are not considered part of the diagnostic criteria because they are relatively common in the population at large as compared with tuberous sclerosis populations. Some of the renal or pulmonary features of tuberous sclerosis are also found as sporadic mutations in otherwise healthy patients. However, individuals presenting these features should seek screening for TSC. It is also known that renal AMLs can be mistaken for renal cell carcinoma. When an individual is diagnosed with tuberous sclerosis, there are a variety of surveillance measures needed to keep them and their family safe. Initially, a family assessment should examine the family tree as far as 3 generations to see if anyone is at risk. It's also important to offer genetic tests to those who are concerned or present some of the diagnostic features. Neurological surveillance begins with an MRI, EEG, and neuropsychiatric assessment. A brain MRI is performed to look for the presence of tubers, subependymal nodules, and subependymal giant cell astrocytomas. An electroencephalogram, or EEG, monitors brain conduction and can detect seizures. A neuropsychiatric assessment is used to create a baseline for the tuberous sclerosis-related neural symptoms, such as behavioral abnormalities that patients and their families can detect. Neurological surveillance requires imaging be repeated every 1 to 3 years. A renal MRI should always be performed to test for the presence of renal AMLs and cysts. These should be repeated every 1 to 3 years. Pulmonary function tests such as the FVC or forced vital capacity and 6-minute walk tests will provide a baseline to compare against in later cases of possible LAM. These pulmonary tests should be performed annually. Detailed ophthalmologic, dental, and dermatological examinations should be performed to determine the extent of manifestations of TSC previously described, including angiofibromas, dental pits, retinal lesions, and more. These should be repeated yearly, with dental exams twice yearly during normal dental visits. Echocardiograms use sound waves to create an image of the heart and to understand blood movement. It is especially important in infants or fetuses identified with cardiac rhabdomyomas. Echocardiograms should be repeated every 1 to 3 years in children until the rhabdomyomas are regressed or no longer a threat. An ECG or electrocardiogram is used to understand the electrical conductivity of the heart. The goal for a chronic genetic multisystem disease such as tuberous sclerosis is to provide the fewest complications from the disease itself, the fewest side effects from treatment, and as little medication as possible. The use of systemic therapies is a relatively new advancement in the treatment of TSC. mTOR inhibitors, or inhibitors of the mammalian target of rapamycin, such as everolimus, have been shown to treat many of the features of tuberous sclerosis, including SAGAs, AMLs, and secondarily epilepsy, LAM, and a variety of dermatological conditions associated with TSC. Everolimus has been approved for use against indications of SAGA and AMLs in TSC patients at maximal doses of 4.5 mg per day and 10 mg per day, respectively. This type of systemic treatment can have some minor adverse effects, most commonly stomatitis, mouth ulcers, nasopharyngitis, and headache when used in patients with TSC. Large Phase 3 studies in 2013 tested the ability of everolimus to reduce the size of tumors, specifically AMLs in the EXIST-2 study and SAGAs in the EXIST-1 study. These studies definitively showed the efficacy of this drug in reducing the size of TSC-related lesions. Anti-epileptic medications, or AEDs, are prescribed to reduce the symptoms associated with epilepsy, and the specific drugs depend on the patient's age, the type of seizures, and other factors. Vigabatrin is the consensus choice for children with infantile spasms. Adrenocorticotropic hormones, or ACTH, can be used as an alternative treatment for infantile spasms if vigabatrin is not effective. Another common drug is lamotrigine, which is used for partial seizures. It's also known as an anticonvulsant. A ketogenic diet is another non-surgical treatment option for epileptic seizures. It requires patients to consume a diet of 80 to 90% fats, and this works because carbohydrate depletion inhibits mTOR and thus suppresses the growth of lesions causing epilepsy. However, this diet is very difficult to maintain and requires strict compliance from the patients and their family members. Patients can also undergo surgeries in hope of relieving their seizures. Firstly, focal cortical resections, or resections of a seizure foci, commonly cortical tubers, can relieve seizures or at least make them less intense. A corpus calostomy is the cutting of the corpus callosum, which will separate the two hemispheres of the brain and can relieve tonic or atonic seizures. However, this is considered a palliative therapy. Lastly, vagus nerve stimulation involves the sending of electrical pulses to the brain via the vagus nerve. This has been shown to decrease seizures by 50% in 30% of patients who receive the treatment. Operative resection of SAGAs is traditionally the standard of care once a SAGA has become problematic. This usually occurs via a transfrontal or a midline transcallosal approach. However, the use of mTOR inhibitors, specifically everolimus, is now relieving the need for surgery in many cases. Shunts can be used in order to relieve hydrocephalus, which is a buildup of pressure within the ventricles, often due to SAGAs. Shunts use a tube in which the cerebrospinal fluid is redirected away from the ventricles of the brain and will take the fluid somewhere else in the body where it can be absorbed safely. mTOR inhibitors have now become the first-line treatment for renal angiomyolipomas, or AMLs, associated with TSC. The secondary measure is now selective arterial embolization, in which the healthy renal tissue is spared and the blood supply to the renal lesion is cut off. This procedure is now primarily used when treating an already hemorrhaging tumor. Lastly, a nephrectomy can be performed as a last resort, in which either part of the kidney, including the lesion, called a partial nephrectomy, or all of the kidney is removed, including the lesion. This is called a radical nephrectomy. And this is typically reserved for select situations as it is quite invasive. There is currently no treatment for LAM, and thus all therapies are supportive in nature. Supplemental oxygen can be given to keep oxygen saturation of the lungs above 85%. Patients with LAM are candidates for lung transplants, however, anti-rejection medications may interfere with seizure medications. Perhaps the best treatment for LAM comes from systematic therapies, such as mTOR inhibitors like rapamycin or everolimus, which have been shown to significantly improve lung functionality. This concludes our discussion of tuberous sclerosis. Thank you for listening.